Good evening, all the students present here. First of all, it is going to be an interactive session. So, if any of the aspirants have any doubt or questions, please drop it in the chat box. Today, topic is nutrition, and the speaker that we have here is Dr. Nilanchal Chakraborty, sir. He is a consultant critical care at Apollo Multi-Speciality Hospital, Kolkata. Sir, you can start. Thank you.
Yes, this is kind of a preliminary course for the EDIC ongoing examining. So on nutrition, so start on how much we know. What is isocaloric diet? We assess what is the nutritional need of each patient at the bedside, and when you reach the energy around the defined target, we call it isocaloric diet. When we reach up to or below the 70% of the defined target, we call it hypocaloric or underfeeding. And when it's just very minimal to preserve only the intestinal epithelium and the brush border enzymes to maintain the immunity of the gut, we call it tropic feeding. It is maybe 500 ml in a day. And we target a protein up to 1.2 to 1.5 gram per kg per day for individual patient, but when it is less than 0.5 gram per kg, we call it is a low protein diet. And never we intend to overfeed the patient, because it will ultimately cause more metabolite of carbon dioxide. So we call it overfeeding when we intend more than 110% of the target feeding calorie. So, who should receive a medical nutrition therapy? It is a therapy, definitely it is therapy for the patients who are in ICU and staying more than 48 hours. It's not just diet. We have to calculate how much is the energy expenditure for each patient, because in critical ill patient, they may be in the hypermetabolic state, almost 50% of the patients. So calorie requirement may be more than usual, and sometimes they are normal metabolic, which is 1/3 of them. And when the patient is basically in cardiorespiratory instability, in shock, requiring vasopressors, we never intend to start the whole feeding up to 48 hours. We keep it as minimum as possible, and we should not go beyond the 70% of the expected energy expenditures in this critically acute phase. So there are some nutrition assessment tools, and nowadays most commonly we use the Nutric score or modified Nutric score or NRS 2002. If the facilities are there, we measure interleukin 6, but otherwise we measure other clinical and biochemical parameters to assess what is the nutritional assessment goal of the patient. So as you can see, if you assess with a Nutric score without the interleukin 6, there is a cutoff of 5 or less than 5 or more than 5. If the patient is at high risk of Nutric score, there is a higher chance of mortality. So patient at high risk of nutritional adverse events or nutritional deficiencies when the Nutric score is more than 5. It is available in the Medcal, no point in memorizing them, but you just have to mention the Nutric score more than 5. They are at high nutritional risk. So while assessing the patient's nutritional need, you have to assess the patient's pre-admission history, the dietary history, the body mass index, the body composition, muscles versus fat mass, and the clinical parameters in terms of biochemistry, the electrolytes, potassium, magnesium, phosphate, comorbidities, and other associated drugs, and predicted ICU length of stay. Then, based on the ideal body weight, you actually try to calculate what could be the calorie and protein need of the patient. These are all available in the Medcal, no point in memorizing, just to understand the concept. So you have to screen for the patient of malnutrition risk using this score, and every critically ill patient staying more than 40 hours should be considered a risk of malnutrition. In terms of physical signs, we need to see for muscular atrophy, edema, water accumulation more than the muscle mass, loss of subcutaneous fat, and mucosal lesions, which may be signs of vitamin deficiencies, micronutrient deficiencies, before we decide what could be the nutritional need. There are different theoretical criteria for assessing the energy targets, but they are rarely used, like the intercalorimetry or amount of carbon dioxide production compared to the oxygen consumption. And we never intend to give more than 70% of the nutritional need or energy expenditure in the first 40 hours. We intend to give only hypocaloric nutrition in the first 1 to 2 days, the early phase, and then after 3 days we gradually increase it to 80 to 100% of the energy need as per the requirement, and targeting to reach it by around 7 days as the patient tolerates. So when we assess what is the nutritional need of the patient, then we target our therapy, that is nutritional therapy. Oral diet is preferred because it is more physiological. If the patient cannot swallow for different reasons, we go for early enteral nutrition, but never the full one. We target a early nutrition, but always a hypocaloric in the first 40 hours. When enteral nutrition is contraindicated or cannot be given, parenteral nutrition usually may be tried, but never within the first 40 hours for critically ill. So some of the trials been done in recent era. One is in the French group of population who compared parenteral versus enteral nutrition, started within the first 24 hours and assessed what is a 28-day mortality or ICU mortality or 90-day mortality, and they tried to achieve almost the full nutrition need in the first few days and found no difference. So why do you prefer enteral nutrition if there is no difference? We need to find out, because in these studies, similarly another study that is a caloric study I'll discuss later, when you use enteral nutrition, the gastrointestinal complications are much more. So somebody may say that okay, parenteral nutrition in terms of mortality may be same and the gastrointestinal complications are lesser, so why not use parenteral nutrition? Because parenteral nutrition is never physiological and it has its own side effects as per the recent data. Similar studies in English population published in NEGM, the calories trial, also showed that the mortality outcome may not be different, but non-infectious complications, maybe in hypoglycemia and all, is basically more in the enteral group, and the gastrointestinal side effects are more in the enteral group. So always there is a controversy whether to use enteral nutrition or parenteral nutrition, but enteral nutrition is physiological. You do not need a special line for giving enteral nutrition. So there are different formulations for it. What are they? It may be polymeric, which is much more preferred because it contains whole protein, it contains fibers, and it contains some long chain triglycerides. But when the patient cannot tolerate it, we go for semi-elemental diet, which contains peptides and some oligosaccharides. But it doesn't contain that much of fibers, so absorption wise, it may be affected, may cause diarrhea. So polymeric feed is always preferred, which is usually the in our situation is a kitchen diet, but it has differences in calories in terms of how they make it. So of course, in terms of polymeric diet, we use a powdered form of different formulations. So as I said already, why polymeric enteral feed is generally preferred over elemental diets? Because polymeric products mimic standard food. It is enriched in fiber, less expensive, and tend to be better tolerated than semi-elemental diet. When is semi-elemental enteral feed is indicated? When the patient cannot absorb the polymeric food, like short bowel syndrome, to improve nutrient absorption in acute severe pancreatitis, or gut allergy to macromolecules such as proteins. So then we use the peptide formulation. So what are the advantages of enteral nutrition? It doesn't require extra central line, so its complications are prevented. There are fewer infectious complications, and of course the feeding is less costly, and it is more physiological and maintains the intestinal integrity. Contraindications, and there are only absolute contraindications when there is bowel ischemia or chances of perforation. So disruption of the GI tract, you cannot feed the patient, or intra-abdominal pressure is high, abdominal compartment syndrome may precipitate, then you avoid enteral feeding. So there are some relative contraindications when the enteral feed cannot be given, expected in next 3 days, and there is life-threatening hypoxia or hypercapnia, gastric aspirate more than 500 mils in 6 hours, or maybe active GI hemorrhage going on, or maybe conditions when the risk of aspiration is too high, or maybe some other things like abdominal trauma, raised intracranial pressure, abdominal pressure, etc. But right now, in today's date, if the patient is having neuromuscular blockers, on hypothermia, on ECMO, even the patient is prone or having traumatic brain injury or severe acute pancreatitis, even the guidelines have changed, and enteral nutrition is no longer a relative contraindication.